Margaret Chen is a 71-year-old retired school librarian from Columbus, Ohio. For the past 6 years, she has taken Lisinopril every single morning. On paper, everything looks perfect. Her blood pressure is well controlled, and her doctor is happy with the results. But Margaret isn't. By noon, she's dizzy. By 2 o'clock, she's completely drained. She can't even finish a chapter of the novel she's reading without falling asleep. Eventually, she starts telling her daughter, maybe this is just what getting older feels like. Her daughter isn't convinced. She encourages Margaret to get another opinion. The second doctor doesn't tell her she was misdiagnosed. Instead, he changes her medication. What he discovers surprises both of them, and what happens next is something everyone watching needs to hear. I'm Dr. William, and if you or someone close to you takes Amlodipine, Losartan, or Lisinopril, this video could completely change how you think about blood pressure treatment. After years of caring for older adults, I've learned something important. These medications absolutely save lives. There's no question about that. The problem is that in adults over 65, they're often prescribed, adjusted, and monitored in ways that leave major gaps. Many symptoms older people experience are brushed off as normal aging, when in reality, they may be side effects of the medication itself. Today, I'm going to share 6 important things that most people taking these medications were never told. Stay with me through every one of them, because number 3 is a side effect that millions blame on aging, even though their medication may actually be responsible. And number 5 involves a blood pressure reading that looks excellent on paper, but could quietly increase the risk of ending up in the hospital. If you or someone you love takes medication for blood pressure, subscribe now, because today's discussion could completely change your next conversation with your doctor. Before we get into the list, I want to give you a simple way to think about everything we're covering. I call it the dose assumption trap. It has 3 parts. First, your doctor prescribed your medication using established clinical guidelines, and that's appropriate. But many people don't realize those guidelines are based largely on studies involving adults in their 50s and 60s, not people in their late 70s who take multiple medications and whose bodies process drugs very differently than they did years ago. Second, the dose that keeps your blood pressure looking perfect on paper may also be quietly causing symptoms you've accepted as part of getting older. Fatigue, dizziness, brain fog, and swollen ankles aren't automatically caused by aging. Sometimes they're medication side effects hiding in plain sight. Third, having well-controlled blood pressure on your chart doesn't always mean it's the best blood pressure for your everyday life. A number that looks ideal during a doctor's visit could actually be making you feel worse every day. That's the dose assumption trap. The numbers look good, so everyone assumes the medication is working perfectly, but no one stops to ask how you're actually feeling. Keep that idea in mind as we go through the rest of this list. Number 1, 3 medications, 3 completely different ways of working, and why knowing the difference matters. Robert Morales is 68, a retired truck driver from San Antonio, Texas. During a routine checkup, his blood pressure came back high, so his doctor handed him a prescription for Amlodipine and simply said, take one every day. Robert asked a reasonable question. What exactly does it do? The answer was short. It lowers your blood pressure. That was the entire explanation. Robert faithfully took that medication every day for the next 2 years without really understanding how it worked or why that specific drug had been chosen for him. That lack of information almost cost him dearly. Here's what Robert was never told, and what many patients still don't know. These three medications lower blood pressure in completely different ways. Amlodipine is a calcium channel blocker. It relaxes the muscles surrounding your blood vessels so they widen, allowing blood to move with less resistance. Losartan belongs to a group called angiotensin receptor blockers, or ARBs. It blocks the hormone that tells blood vessels to tighten. Lisinopril is an ACE inhibitor. Instead of blocking the hormone, it prevents your body from producing the enzyme that creates it in the first place. Why does that matter? Because every one of these medications comes with its own set of side effects, possible interactions, and risks that become increasingly important as we get older. Knowing which one you're taking isn't just useful information, it's essential. So here's your first action step. At your next appointment, ask your doctor, why did you choose this medication for me instead of another type? If you don't receive a clear answer that's specific to your situation, keep the conversation going because you deserve to understand the reason behind your treatment. And it's within those differences that the side effects begin to matter, especially with one of these medications. Number 2, the side effect many doctors call normal, even though it shouldn't be. Linda Hargrove is 73, a retired postal worker from Richmond, Virginia. She had been taking amlodipine for 4 years, and for most of that time, her ankles stayed swollen. Not just slightly puffy, but swollen enough that she stopped wearing the shoes she'd worn for most of her adult life. She mentioned it to her doctor more than once. Each time she heard the same response. It's a common side effect. It's harmless. Don't worry about it. Linda trusted that advice. She adapted by buying wider shoes and putting her feet up every evening. She accepted it until one afternoon when the swelling became so severe that her daughter took her to urgent care. That's when doctors discovered the swelling had been hiding a much more serious circulation problem that had gone unnoticed for over a year. This situation is far more common than many people realize. Research published in the Journal of the American Heart Association found that swelling caused by amlodipine affects up to 10% of patients, with the risk increasing as people age and as doses become higher. In everyday practice, it's often minimized, but the reason it happens shows why it deserves much more attention. Medications like amlodipine widen the arteries, but don't widen the veins at the same rate. That imbalance allows fluid to leak from tiny blood vessels into the surrounding tissues. Younger bodies often adjust to this change. Older adults, especially those with weaker circulation, may not. Swelling reduces mobility. Less movement leads to poorer circulation, which then increases the risk of falls. That's not harmless. If your ankles swell while taking blood pressure medication, don't assume it's something you simply have to live with. Ask for a complete medication review. There are options. Sometimes switching to an ARB, lowering the dose, or combining smaller doses of different medications can solve the problem. Never accept it's normal as the final answer when a side effect is changing the way you live. If you or someone close to you has experienced swollen ankles while taking blood pressure medication, type swelling in the comments. I'd genuinely like to hear your experience, but amlodipine isn't the only medication that can quietly create problems. If you're taking lisinopril, what comes next may sound very familiar. Number 3. The cough that never seems to go away and what it may actually mean. James Whitfield is 69 years old, a retired electrician from Knoxville, Tennessee. About 3 months after starting lisinopril, he developed a dry cough that simply refused to disappear. It wasn't caused by a cold, and it wasn't allergies. It started as a slight tickle in the back of his throat, then slowly became a constant cough that stayed with him day after day. He visited a lung specialist, had chest x-rays taken, and even spent sleepless nights worrying that he might have lung cancer. For 8 long months, not one doctor asked him a simple question: "What medications are you taking?" This isn't an uncommon reaction. Studies show that up to 15% of people taking ACE inhibitors develop this type of cough, and some research suggests the real number may be even higher. Medical experts have explained exactly why it happens. Lisinopril blocks the enzyme that normally breaks down a substance called bradykinin. As bradykinin builds up inside the lungs, it irritates the airways and triggers a persistent dry cough that no cough syrup or over-the-counter medicine can fix. For older adults, this is much more than a minor inconvenience. It interrupts sleep, causes dizziness during coughing spells, increases the chance of falling, and gradually affects everyday quality of life in ways that are easy to overlook but impossible to ignore. If you've developed a new, unexplained cough after starting an ACE inhibitor, like Lisinopril, tell your doctor as soon as possible. In most cases, switching to an ARB, such as Losartan, solves the problem. This side effect is well documented, widely recognized, and completely manageable. It's never something you should simply be told to live with. After hearing that, Losartan may sound like the safer option, but there's another issue people taking Losartan need to understand. Number 4, the hidden potassium problem that often goes unnoticed. This time, I won't share a patient story because the hospital data itself paints an even more concerning picture. Both ARBs like Losartan and ACE inhibitors like Lisinopril have a well-established effect that doesn't receive nearly enough attention during routine medical care. They can raise the amount of potassium in your bloodstream, a condition known as hyperkalemia. Research published in the American Journal of Kidney Diseases shows that hospital admissions related to hyperkalemia among older adults taking these medications are surprisingly common and continue to increase. Here's why it happens. These medications reduce the activity of a hormone called aldosterone. One of aldosterone's jobs is to tell the kidneys to remove extra potassium from the body. When aldosterone levels fall, less potassium is eliminated, allowing it to build up over time. Now add the realities of aging. Kidney function naturally slows down as we get older, making it harder to remove excess potassium. Then consider the foods many older adults are encouraged to eat, including bananas, spinach, potatoes, sweet potatoes, and beans. They're all healthy choices, but they're also naturally high in potassium. Add potassium supplements or salt substitutes, which many health-conscious people use without much thought, and potassium levels can quietly climb even higher. The most concerning part is that hyperkalemia often causes no warning signs at all until it suddenly triggers a dangerous heart rhythm problem. That's what makes it so serious. So what should you do? If you're taking Losartan, Lisinopril, or any medication in the ACE inhibitor or ARB family, your potassium levels and kidney function should be checked regularly, at least every 6 months. This isn't optional. It's an essential part of safe treatment, yet far too many people never receive this monitoring. At your next appointment, ask one simple question: when was my potassium level last checked? If nobody can give you a clear answer, that's a concern worth addressing. And if you've been taking one of these medications for more than a year without ever having your potassium tested, type "never" in the comments. You may be surprised how many people are in exactly the same situation. But the next issue worries me even more as a physician because it's rarely discussed openly. Number 5. When your blood pressure becomes too low and the medication itself turns into the risk. Dorothy Flanagan is 76 years old, a retired teacher's aide from Scranton, Pennsylvania. Her blood pressure was what her doctor proudly called perfectly controlled, 118/70. At every appointment, he smiled and said, "Your numbers look great, Dorothy." And she smiled right back. But behind those good numbers, something else was happening. Dorothy kept falling, twice in her kitchen, once in her driveway, where she scraped both hands trying to catch herself. Then one Tuesday morning, her daughter found her lying on the bathroom floor. She had stood up, everything suddenly went black, and she collapsed. At the emergency room, doctors diagnosed her with orthostatic hypotension. Every time she stood up, her blood pressure dropped dramatically. The medication that was meant to protect her heart had quietly become a threat to both her brain and her bones. The research supporting this is becoming stronger every year. Follow-up analyses from the SPRINT trial, along with a widely discussed 2023 study published in JAMA Internal Medicine, found that aggressively lowering systolic blood pressure below 120 in adults over 75 was linked with significantly higher rates of falls, fainting, acute kidney injury, and serious electrolyte imbalances. Because of this, the American Academy of Family Physicians has recommended more flexible blood pressure targets for many adults over 75, suggesting that a systolic pressure below 150 may actually be safer for patients living with several medical conditions. Here's why this matters so much. Medication lowers your blood pressure aggressively. You stand up from a chair or get out of bed. Blood collects in your legs because your blood vessels can't tighten quickly enough. Your brain suddenly receives less blood. You feel lightheaded. Your vision starts fading. You reach for something to steady yourself. You miss. Then you fall. A broken hip follows. Surgery comes next. Then a hospital stay. Possible infections, weeks of immobility, muscle loss, cognitive decline, and depression. All of that can begin with a blood pressure reading that looked perfect on a medical chart. So here's what you should do. Ask your doctor to measure your blood pressure while you're standing, not just while you're sitting. Request orthostatic blood pressure checks during your visits and have an honest conversation about whether your current target truly fits your age, your history of falls, and your overall health. For many people, a systolic pressure of 140 may actually be safer than 118. The best blood pressure isn't always the lowest one. Number 6. The blood pressure medication checkup. 5 questions you should take with you to your next doctor's appointment. I want you to save these, write them down, or print them out because they could completely change the way your blood pressure is managed. Question 1. Why am I taking this specific medication instead of another type? You deserve to know why your doctor chose Amlodipine over Losartan or Lisinopril instead of an ARB. The answer should be based on your personal health, not a general explanation. Question 2. What is my blood pressure when I'm standing, not just when I'm sitting? A reading taken only while you're seated tells only part of the story. The standing reading could reveal something that helps prevent a dangerous fall. Question 3. When were my potassium levels and kidney function last checked? If you're taking an ACE inhibitor or an ARB, and these tests aren't being monitored regularly, that's an important gap in your care that needs to be addressed. Question 4. Is my current blood pressure goal still appropriate for my age and overall health? The target that's right for a healthy 55-year-old isn't automatically the right target for someone who's 78. Asking this question opens a discussion that many physicians appreciate, even if they don't always bring it up first. Question 5. Could any of my other medications or supplements be interacting with this one? Blood pressure medications don't work in isolation. Common pain relievers like NSAIDs, certain antidepressants, potassium supplements, and even some over-the-counter cold medicines can either reduce their effectiveness or increase the risk of side effects. Any doctor who takes your health seriously should welcome these questions. In fact, asking them shows that you're actively involved in your own care. And if your concerns are brushed aside or dismissed, that may tell you something important about whether your current medical relationship is truly meeting your needs. Now let's return to Margaret Chen, the woman we met at the beginning who believed she was simply getting older. Her second doctor didn't tell her she'd been diagnosed incorrectly. Instead, he reduced her medication dose and switched her to a different class of blood pressure medicine. Within just 3 weeks, the dizziness disappeared. Her energy returned. She smiled and told her daughter, "It feels like I got 2 years of my life back." Her blood pressure remained well controlled, but now the number on the chart finally matched the quality of life she was actually living. That's the message I want you to remember. A blood pressure medication should help you live better, not simply help you live longer. If your prescription keeps your numbers looking good while quietly taking away your energy, your balance, your clear thinking, or your confidence, then it's worth asking whether your treatment still fits your needs. You never agreed to accept those trade-offs without question, and you have every right to discuss them with your doctor. The ideal blood pressure isn't always the lowest possible number. It's the one that allows you to stay healthy while still enjoying your everyday life. If you're taking medication for blood pressure, I'd love to hear your experience. Which medication are you on? And has anyone ever sat down with you to discuss whether it's still the best choice for you? Share your story in the comments, because your experience may help someone else who's dealing with the same situation. And if today's information changed the way you think about your treatment, please share this video with someone you care about. Don't forget to subscribe so you won't miss future videos. I am Dr. Sarah Mitchell, and I'll see you in the next one.